Thank you very much, Donna. Is everybody able to hear me? Pardon? Not well? Is that better? Very good, very good. You know, I now understand why they asked me to be here, because we are that one state that supports every other state in the country. So, you know, although they call us the 50th, we're the support. So we're proud of that fact. That's why some of us are a little bit heavier than the rest of the country, because we have to maintain that weight for strength. I appreciate the opportunity to be here today. I have had the pleasure of working with the Louisiana Department of Insurance and their health division for the last 9 months. I've been here off and on during that period, working intimately with them to establish a bill that would allow Louisiana to become compliant with the federal mandated effective rate review program that came out of PPACA and the Health Service Act. In that work with the department, I'll just say is in the beginning that while I've worked with many states, many institutions, I've never worked with a group of people that are so talented, so intelligent, and so dedicated to doing the exact right thing all the time. I'm very proud to have been associated with them, and you should, as a state, be very proud to have them working with Commissioner Donnell. They do an excellent job. A little bit of background on rate review. The Healthcare Reform Act, as brought forth by PPAC and the Health Service Act, they came together and Congress wanted to give power back to the individuals in making healthcare decisions. Commissioner Cassidy earlier mentioned that was the most empowering and important thing that you can do, is provide healthcare decision makings back to individuals. Congress, is their stated intent, wanted to do that in any number of ways. One of the ways that they decided to do that is to ensure that consumers get value for their dollars. Congress wants the decision makers to be the policy holders. They want those to be the people that are making decisions on health care, not necessarily the health insurers, not necessarily the physicians, but front and foremost, the consumers. One of the things that they did to ensure that was they implemented a regulation to mandate that rates be, health insurance rates in the individual and small group market be publicized. And they want the consumers to have all the information that they can to make decisions and appropriate decisions regarding purchasing policies. It goes a little bit hand in hand with the exchange, but it's different. As you well know, some states, Louisiana particularly, have chosen not to participate in the exchange. But what the federal law does require is that the Department of Insurance regulate rates. It is not an option for the state not to regulate rates unless the state wants the federal government to regulate the rates. The federal government says we are not in the business of regulating rates, and as a policy, HHS should not be in the business of regulating rates. But if a state doesn't do that, then it says that it will certainly regulate those rates. Louisiana was one of the few states, there's about a third of the states that did not have an effective rate review program when the law was passed. The law was passed to essentially allow for departments to have all of the information on health rates and to publish those rates and to have a mechanism to allow the public to review those rates and to make determinations whether those rates were reasonable or not. Because Louisiana was in that category that did not have an effective rate review program, the federal government said, you need one or we're going to take control. Right now, rates are being regulated, health rates are being regulated largely at the federal level. To get compliance with federal law, Louisiana needed to have a rate review program in place to make sure that it could fulfill its duty to regulate rates. One of the intentions of, some of the intentions of Congress when they developed the rate review regulation was to develop a system that put the policyholders at the decision point, that decisions could be made by the policyholders, that a thorough review be conducted at the state level to ensure that rates were reasonable. And furthermore, that the insurers or the insureds get advance notice of any changes with respect to their policies. So what the federal government did with this intent was they drafted into the PPACA as part of the Public Health Service Act rate review regulation. And it's very simple. It's not a very difficult concept, although implementation within the existing laws gets a little bit tricky. But there are just a few key components to rate regulation that you'll need to know. What it does is it allows health insurance issuers, or requires health insurance issuers, to produce information with respect to their rates for the individual and small group market for any increase over 10%. For the department would then be allowed to review those rates to determine whether they're reasonable. HHS said that reasonableness is not going to be necessarily a state-by-state decision, so that there's some uniformity. All states will review for reasonableness using 3 criteria: whether the rate is excessive, whether the rate is unjustified or unfairly discriminatory. Any rate increase that meets any of those criteria would be found unreasonable. The department, or the HHS, went further to say that if you've got a finding of an unreasonable rate, that you should publish that rate and publish your findings so that the consumers can make decisions based on that information. They can see that a rate increase for perhaps their policy or a policy that they're considering is unreasonable. The final part of the federal law's mandate is that not only does the department have to publish those rates, but HHS will publish them and health insurance issuers will publish them as well to provide as much information as possible for the consumers. Now, publishing notice of an unreasonable rate is only one part of rate regulation. And that's as far as the federal government went on the law. However, the federal government did say that in a very important aspect of rate regulation, which is being mandated by the federal government to the states, a very important part of rate regulation is not necessarily the review and the finding of reasonable or unreasonable rates, but it's the finding of approval. If a rate is found to be unreasonable, the federal government said, it is very important that the state take some action. Now, it didn't say that the state had to take action in order to have an effective rate review program, but the federal government said that it was an important aspect of regulation which we require of the state. Many of the states, between 2/3 and 3/4 of the state, have some mechanism for approval in their health insurance rating laws. Some states act on it, some states don't. But most of the states do have approval as part of the process. It's not just file and use in most of the states. Most of the states have some form of approval, so that when consideration is made and a detailed study is performed, which is required by the federal government, when the Department of Insurance conducts that study, that it means something. That when you find, what the department finds that a rate is reasonable, hit the market, let it go, let as many people jump in as possible. Promote those policies. But if a rate is unreasonable and that the finding is made and the details are there that either don't justify the rate or show that the rate is excessive or unfairly discriminatory, then the department should take some action and limit those rates. Disallow those rates from hitting the market. Now, reasonableness, unreasonableness is not a high burden. I mean, a heavy burden to carry. It's not a high bar to reach. Donna knows that in the law, reasonableness is just about average. What would the ordinary person do, or the ordinary entity do, with the information that is provided? Reasonableness is not a difficult concept to grasp, and it is not something that is onerous on health insurance issuers at all. It's just, are you acting reasonably? Are you taking prudent action to prepare rates? And are your rate increases appropriate? Rate increases are often appropriate, and there's nothing inherently wrong with a rate increase, and the department does not want, nor did the federal government want to suggest otherwise. What the federal government did mandate, and the department will ask for action to be taken on, are those rates that go outside the bounds of reasonableness, that are excessive, that do discriminate unfairly. It's not a difficult concept, and it's not a difficult burden to health insurance issuers to carry. In developing the state's rate review law, the department and I took into consideration many, many things. We spent many, many days and hours studying. We had to figure out how to best drop this federal ball into the existing regulations, the existing legislation in the state. It would be easiest to have just written a law to exactly follow the federal mandate. That is not a difficult task to carry out. However, reconciling that with existing law, reconciling that with existing procedures that health insurance issuers are taking in this state would become very complex and very cumbersome, not only to the health insurance issuers, but to the department as well. So what we had to do was figure out the reasons behind the federal mandate and how to best implement them here with as little disruption as possible. We did that by reviewing and studying what the regulators meant when they said that the state had to have an effective rate review program. What were those criteria that would allow the state to regulate rates and not have to pass on rate regulation to the federal government? We reviewed the state laws, how best to reconcile and tie together aspects of the rate regulation to existing pieces of the law. We studied model acts from across the country. Many states, if not all states, have reformed their rate regulation to follow up on the federal mandates. We studied those acts. We considered the marketplace. We spent many, many hours and many days talking about the marketplace and getting input from outsiders, actuaries, experts from all across the country to ensure that whatever we were developing was consistent with what the marketplace is already doing. We didn't want to ask for information or demand information that is not available, that is not already being used by health insurance issuers. And we had to consider the impact that those requests and mandates would have on health insurance issuers and the policyholders. We had to reconcile all of that together to come up with rate review regulation. What we've done after we reviewed that, after we determined what all needed to be included and how best to shape and mold this, we took a look at the existing statutes and we said those statutes needed to be modified. The existing rate regulation, community rating standards for small and individual groups should be modified, tailored to fit the federal mandates. When we were doing that, and we were studying what other states were doing, when we were studying what the federal government required of the state, it was not a difficult leap to say, well, implementation of the federal mandates only take the state so far. And to best serve the state, additional aspects of the law need to be incorporated. And so, incorporated within the law are not only the small group and individual markets, but also the large group markets. Now, some reaction to that has been a little difficult, a little bit challenging. The department has been challenged by adding large group to the market. Large group was added to the market very simply because large groups are going to be, portions of existing large groups are going to be regulated anyway. Small groups now under the law in Louisiana are regulated, and small groups are included between 3 and 35 employees during the year. Federal mandate changed all that. Federal law now says it has to be between 1 and 50. Then the federal law says, yeah, but we're going to change that again and raise it from 1 to 100. So the department looked at that and said, well, what are we going to do? Ask the insurers to change twice, their models twice or 3 times, get it up to 3 to 35, get it up to 1 to 50, then get it up to 1 to 100. That would be taxing. That would be challenging. So if you're going to move it from 3 to 35 to 1 to 50 to 1 to 100, it makes perfect sense to move it now from 1 to 100. Those are portions, anything outside of 35 includes large groups now. So those would be regulated now. So to include large groups in the rate review is not an onerous, or it is not overly difficult to realize. It's not a long jump to go from 35 to 100. So the review for large group will be included. As I mentioned earlier, another key aspect that was added is the approval process. Again, approval is, as the federal government said, an important function of rate regulation. The federal government mandates the rate regulation and says the important pieces may not all be there. States, we want you to take action that you deem reasonable to ensure that you are regulating rates, to ensure that whatever rates that are instituted in your states are reasonable. So that is another aspect that is a little bit different from federal law, but is much like most of the other states. Between 2/3 and 3/4 of the states use that. So in the law, we've got Title 22, Section 1091 through 1099. That's where all the changes are made. There's a bill, House Bill 908, that addresses all these changes. And I won't go into exact detail on all of the language of that bill, but suffice it to say, no changes were made where they were not required. So as much as possible, the existing law, the existing environment within which you work stays the same. Not much changes unless it's required under the federal law, or as I've discussed. There are some, anytime you examine a law, anytime you examine the environment in which you work, you've got to know a few things. What is the scope of the law? How far does it go? And what are some of the key provisions? What do I need to understand about the law? Title 22, Section 1091 takes you there. Existing Title 22, Section 1091 established this as a playing field in the definitions already. What we've done is we've enhanced that to fit federal standards. Those that are affected include individual, small group, and large group. However, it does not include health and medical savings accounts. Those are already accepted under the law. There was no reason to bring them back. There was no reason to regulate those. They're not regulated now. They don't have to be regulated by the federal law, so why do it? Another aspect that was carved out are high deductible plans. Again, high deductible plans aren't regulated now. Why require that to be regulated in the future? Accepted benefit plans, those limited scope and dental benefits, things like that, are not required to be included, not required to be regulated. And grandfathered plans. No grandfathered plans are required to be regulated under the federal law, so there was no need to require them to be regulated under this law. So you've kind of got the scope of who's affected. Large, small, and individual, except those that are health savings accounts, medical savings accounts, and those others that are listed. Again, part of the key definitions, what do these words mean? Small group, as I said, goes from 1 to 100. Under the bill, it's maybe 1 to 50, but that's going to be changed to rectify or reconcile other bulletins and regulations passed by the department. So small group will go from 1 to 100, and that's the following of the federal law that is upcoming that will be imposed across the country. And then what is an unreasonable rate? To understand some terms, you have to introduce new terms. All the department is asking for in finding unreasonable rates are rates that are excessive, unfairly discriminatory, unjustified, or otherwise unlawful. That's not bad. I mean, that's not a hard concept to grasp. It's not a heavy burden, as I mentioned earlier. Excessive rates are those rates that would result in an MLR, medical loss ratio, that's below the federal standard, or those in which the premium charged is unreasonably high in relation to the benefits provided. Not difficult. Unfairly discriminatory rates are those rates that treat two people with the same case characteristics, same profiles, differently when there are no expected differences in anticipated costs. That's easy to get. Why would you charge two people that are identical with no expectation of anticipated cost differences, different amounts? If those are charged, those would be unfairly discriminatory, and those would be unreasonable. And rates that are unjustified, rates that don't have that support to justify the rate increase or the rate charged, those that do not have the actuarial basis to create that rate system. If you've got a rate that is not justified, it should not be allowed. It is unreasonable. Otherwise, you just have some arbitrary rating system that has no basis in actual expenses, costs, whatever is associated with the rate. And rates that are unlawful, otherwise unlawful. It doesn't change the law. It just says if you otherwise don't comply with a rate, otherwise doesn't comply with the law, it will be found unreasonable. It'll be posted when necessary, and it would be disallowed under the new system. So, kind of got the key definitions, kind of got the playing field, the scope. The heart of the rate review regulation is found in section 1092, Title 22, section 1092, and it's not difficult. While a lot of time and energy was put into creating the law and tying it together, a lot more time and energy was put into creating a simple system. I heard somebody mention earlier that the best method that the government can take is a keep it simple, stupid approach. We spent a great deal of time trying to keep this as simple as possible, to keep this as understandable as possible, so that not only could consumers understand it, not only could industry understand it, but the general layperson, those people that aren't involved in day-to-day healthcare decision making. So we tried to make this as simple as possible. And it's really simple, and I'll go through the key parts with you. All rates are required to be filed, will be required to be filed with the department. All healthcare rates in that market, we'll go back to the scope, large, small, and individual market, would need to be filed. Now that does not include only rate increases. They would include new rates for new products. Now, to be sure, the federal government only went so far as to say rate increases are required for an effective rate review program, not for new products. But in order to have a baseline, in order to have a proper, if you've got a rating system that's going to review for reasonable or unreasonable rates, there's no sense in letting new products hit the market that don't have to meet the same standards. So in order to have a level playing field with existing products and new products, the standards should be the same. So everything would be filed with the department. Everything would have to be filed within 105 days of implementation. If a rate change or rate increase needs to be introduced, send it in 105 days before the rate increase will take effect. Everything will be electronically filed under the SURF system. All the rating has to be, all rate changes or new rate product rates will have to be accompanied by an actuarial memorandum, we spent a great deal of time working with actuaries, both with the department and outside the department across the country, to determine what are healthcare actuaries using and what do healthcare actuaries need for a review. And what we did was we took whatever was being used in the market and we said, okay, whatever's being used needs to be submitted to the department. That's only understandable. It's only reasonable to expect that if a healthcare actuary in the development of a rate asks for or needs or utilizes certain information, certain key pieces of information in the development of those rates, that the department's actuaries would need the same information. Because if the the health insurance issuers' actuaries believe that the rates were reasonable, with that same information, the department can find that a rate would be reasonable using the